Dr. Sarah Warren is one of our haematology consultants who's going to talk about acute leukemia and what we need to do. So just largely case-based, and this is off the back of I'll take my mask off a particularly traumatic case in October in A&E, and liaising with Emily and with some of the with Emily, who suggested it might be a good idea to just give you guys a bit of a heads up of where you might be needed with our to help us really. So I'm sure you guys have, a lot of you, particularly the registrars, we've seen a lot of our patients on here, and they often come to at the point where we've treated them and they've fallen apart. We've given them now our poisons, and they're reacting against it, or they've got horrible invasive infections. This is more about those when they first present, what can go wrong at the outset. A bit hasty. So yeah, so acute presentations of AML and ALL, what can go wrong, where you guys come into it, where's the role of critical care. I'm particularly focusing on DIC, hyperleukostasis and tumor lysis syndrome, which are all to some extent tied in together, and where you get one, you're more likely to get the other. A very brief, there's literally one slide overview because you guys don't need to know the ins and outs of the haematology. But, often, say AML and ALL, first thing to say is often they're indistinguishable clinically. So a patient comes to us and we suspect they've got acute leukemia, and we often don't know which one it is. They can present with pancytopenia, so they've had a blood test for whatever reason, and it's showing pancytopenia, maybe with blasts on the film. Or they can present with a low white cell count or a really high white cell count, and then symptoms of bone marrow failure. So whatever's going, whether they've got a high or a low white cell count, the white cells they're making aren't normal, and they're usually not making normal numbers of platelets and red cells. So they've got anemia, thrombocytopenia, and neutropenia. So usually infections, bruising and bleeding. It can be an incidental finding. And then prognosis-wise, in very broad terms, we usually get remission up front in about 80% of young people. All comers, young and old people, that's 60% up front. Long-term survival is less than that, and that's largely because it's a disease that increases with age. AML we're talking about now increases with age, so as you get older, their prognosis is worse. And that's stratified by various genetics, chromosomal changes and things, which you don't need to worry about. So case one is the case that prompted this talk. So AM was a young 26-year-old gentleman, no past medical history at all. I've directly lifted these from our M&M presentation, so I didn't look through them, but if there's any spelling mistakes, they're not mine. So first of all, we presented, there's a very, very short history, so presentations to his dentist and his GP. So firstly, on the 3rd of October with a dental abscess. I think it was slightly before that actually, but a dental abscess, and he was given amoxicillin and metronidazole. He was then seen a few days later. There was only minimal infection remaining after his first lot of antibiotics, and he was given a sick note by his GP at the same time. Then on the 6th of October, he went back to his GP because this time he still had ongoing symptoms of this abscess. He had a bit of diarrhea and he collapsed on the toilet. He sprained his ankle when he collapsed. They looked at the ankle, didn't think there was any injury, gave him some NSAIDs, gave him some more antibiotics for his abscess, and sent him home. He was essentially a 26-year-old with an abscess. You know, I can't put my hands up and say I'd have done anything different. After the weekend, so on the Monday, the 10th, he was seen at 9 AM. He'd had ongoing diarrhea over the weekend and a bit of crampy tummy pain. His dental abscess had largely resolved, but was still there, so the GP gave more antibiotics, but realised that something not quite right, so safety net said, come back if you don't feel well. He did go back at 5 PM that evening. He'd not passed urine since 9 AM. He had severe abdominal pain. I think at which point the GP documentation from the ambulance sheet says he looked unwell. His heart rate was 170. He was hypotensive. He had a temperature of 39 and he was hypoxic. He was pale, dehydrated. He had some epigastric tenderness. They rightly thought, okay, this chap's septic, and they called 999. While he was there, they put a cannula and gave him a bolus of fluid. Ambulance was on the scene within 20 minutes. It had stats of 77% on 15 litres at this point and was getting a little bit confused. He was given another bolus of fluid on the way in. His blood pressure was holding a little bit better. He arrived at about 7 o'clock in A&E. When he arrived, he then had some quite profuse PR bleeding. He was clearly acidotic, and then had this full blood count that showed a white cell count of 334. His platelets were 45. His clotting sample just completely clotted in the tubes, despite some repeats. He was given lots of Hartmann's. He was given some tranexamic acid. The MHP was activated at 8:45. In total, he had 11 units of blood. He had 4 FFP. Cryo was prescribed, but he didn't get it. By this point, surgeons had been called, ITU had been called down. He had art lines inserted, a central line. He was started on an ORAD infusion, probably only about an hour and a half after he'd got into A&E. The surgeons came down, wanted the results of the CT, understandably. He was hypertensive still, his hemoglobin was dropping, he was still having PR bleeding. By 9 o'clock, despite all the Hartmann's, despite support of his blood pressure, his pH was 7.2, lactate was 13. He was confused, so he went down and had his CT head and a CT cap, and he'd had a right-sided subdural hemorrhage with some subarachnoid hemorrhages, some parenchymal hemorrhage as well. And then his CT showed, I think they then reported it and looked at it the next day. They couldn't quite tell what was going on, but essentially they thought at one point they thought there was volvulus, there was intramural hemorrhage, there was venous gas. And actually the reason I put this one up, you might not be able to see it quite so well, but you can see there's a surgical emphysema in the fascial planes. So you can, and by this point he had surgical emphysema tracking down his legs. In the meantime, I was literally drinking a cup of tea in my pajamas when I had a phone call from my reg saying there's a man in A&E with what it's like up with 300. It looks like APML. So we all sort of ran to A&E. By this, we went with our plan to maybe start chemo, thinking what we thought it was. The ITU reg was there, so Emily was there, and Emily from A&E was there as well. And they were, I had to do my haematology bit and say, are you sure this isn't survivable? And they said, he's having boluses of adrenaline, and his systolic still 60, it's definitely not survivable. At which point, sadly, at this point, he started having an upper GI bleed as well. He was peri-arrest, it was felt to be unsurvivable, so I arrived in A&E and went with the A&E consultant, sadly, to tell his family that he was dying, and he had died by 11 p.m. So you can see how that was incredibly traumatic for the team involved, for the family, for our reg, who'd had a fairly similar situation the day before, which is, so yeah, what prompted really this talk. So, and then afterwards, he had blood culture results, and he had Clostridium septicum, which is almost universally fatal. So with that and a white cell count of 300 because of acute leukemia, he was not going to survive, which I think is actually really helpful for people to know, that there's literally nothing anybody could have done, but absolutely with a 26-year-old, it's absolutely worth trying. You're never going to not try. And it wasn't actually APML, which is what we thought it was, and I'll talk about that a little briefly a bit later on. But it was another subtype of AML that causes tissue infiltration and DIC. So we never got a clotting. We didn't prove he had DIC, but the blood was clotting the tube and it was bleeding everywhere. I'll kind of do an overview of these two cases at the end. So that's a blank one at the end, and talk about learning points. But just to kind of balance that rather depressing story, I present a different one where things can have a different ending. Not spoiler there, but so it's a 56-year-old gentleman who had hypertension, pre-diabetic, but otherwise fairly well. He attended A&E with malaise, fever, chest pain, and shortness of breath. He had a new oxygen requirement, was hypotensive and tachycardic. So they felt that he was probably septic, and they didn't know why he was hypoxic. He had a white cell count of 39 and low platelets. They did manage to get clotting off him, and he had a coagulopathy. His fibrinogen was actually still okay, but his INR and APTT ratio clearly abnormal. He had an AKI and a huge CRP. In A&E, they sent him for a chest X-ray and CTPA. It didn't show any PE, but however, there were effusions and a pericardial effusion and evidence of coronary artery disease. So this is not exactly his, but it's kind of what we saw. These are a particular type of blast, which again we'll talk about, called promyelocyte. So this is a subtype of AML called APML. These are the phase after your most immature primitive stem cell as promyelocyte. It's about 2 stages before they get to a neutrophil. This is what they look like. So they're full of granules. These things are called hour rods. And when you see this, you worry because I'll explain why we worry. He was transferred to OAU. We started him straight away on Atra, which is the antidote for this type of leukemia. 4 hours after his admission, he had blood and platelets, but then 7 hours after he started deteriorating. His EWS went up to 10. He was, because of largely driven by his pyrexia, but he was hypoxic, he was tachypneic. ITU came to the rescue at that point. Thank you, guys. Before we got into ITU, he had rasburicase and doxorubicin, which is our kind of emergency chemotherapy. On ITU, he carried on transfusions. So he had a worsening coagulopathy before it got better, so I haven't given him treatment. And in total, he had, when I added up, it actually wasn't all that much, but he had quite a lot of blood products. And on day 3, his white cell count still hadn't budged, so we gave him the more definitive treatment for this subtype. And then he sort of started developing more cytokine type symptoms. So he had lots of fluid overload, increasing oxygen requirements, pleural effusions, pericardial effusions. And we queried something called differentiation syndrome, which we'll come to talk about, and he started on some steroid. You guys managed him brilliantly. He had 6-7 blood tests a day, making sure his kidneys were holding up with the treatment we were giving. He had an echo on day 3, which, because of the pericardial effusion, which showed a small mobile structure on the mitral valve and some mitral regurg. He had ongoing blood pressure support with inotropes, high flow nasal oxygen. He had an AKI, but he didn't need renal support, and maintained his urine output. And basically, you guys kept him alive, and he was discharged and onto Ward 41. It doesn't stop there. It got more and more complicated. He then had a radial artery thrombus, so he started on some low molecular weight heparin. About a week later, he got some new confusion, and he had on a CT head, it showed an enhancing lesion, and we were questioning if this is related to leukemia or is it something completely unrelated. He also was having ongoing pyrexia and fever, as all haematology patients do, and he had some right lower lobe consolidation and then a splenic abscess, which was a bit of a curveball. So any thoughts about what might be going on here? If I go thinking about what the investigations on the previous slide, it will become, we didn't think about this one, only when we kind of looked back towards investigations. So he then, yes, he did. Yeah, so if you think about it, do you think these things could be related? Yeah. So when we suddenly went, oh, a penny kind of dropped, and we were like, oh, is this what's going on? So we at this point we realised had a repeat echo which showed similar appearances. His mobile structure was still there. The CT report had suggested getting an MRI that showed multiple infarcts, likely possibly septic emboli, and they picked up a possible aneurysm, so suggested an MRA. This bit is relevant. So in the background, he was hyponatremic. He was having lots of biochemical imbalances. He was being chucked antibiotics, chemotherapy, fluids. So on the background of everything else, he was hyponatremic, which you kind of manage, but perhaps you do pay attention to, but does become relevant. He was still confused. He was dysarthric, dysphagic, bedbound. This is a chap who was an IT consultant or something. And then we got the MRA as suggested, which then showed he's probably got central pontine myelinosis as well, which, although we didn't correct his sodium very quickly, I think you normally get with hyponatremia when you correct too quickly, but I think it was probably that jump from 145 to 155. That's the only conclusion we could come to as to why that happened. So we corrected sodium. He had a TOE that confirmed infective endocarditis. He had his high-dose meropenem and ceftriaxone. At this point, we're having multiple conversations with him and his family. We weren't quite sure how much he was taking on because he was dysarthric, dysphagic, a bit confused still, and we're thinking it's really unlikely he's going to survive this. He had his bone marrow biopsy and he was in complete molecular remission, so we'd completely kicked the leukemia out of the field. Just to throw into the mix, he then had some visual loss and had a branch retinal artery occlusion as well. And he finally went home nearly 2 months after he'd come in, walked off the ward with crutches, having been completely bedbound. He'd swallowed, returned, he was eating and drinking normally. We changed his chemotherapy so he wouldn't get any more cardiac damage to arsenic and Atra. And he completed his 4 cycles in May and now comes back to clinic every 3 months, and he's back to work, back to functioning fully. So that is a success story. And I think an example of when it looks like things are falling apart and it looks like there's no hope, but actually people can survive. So the learning points from these two cases are, so DIC in acute leukemia, and it's usually caused, you have a high cell turnover, so it's more likely to occur when you've got high white count AML. And that's because you have a high turnover cells, they express tissue factor, which then triggers your coagulation cascade. You then get consumption of your comag factors, and then the leukemic cells release cytokines, which then feed into the coagulation pathway. So you get this consumptive coagulopathy, so a DIC. And you most commonly get it with a monocytic subtype. So if we ring you and say this is a high white cell count monocytic AML, that's why we're worried, because it can cause real problems. And APML, which I have another slide on that. So really, the way to manage it is we aggressively manage the DIC according to targets. And usually, if you ring a haematology reg about a patient with DIC about anything else, we'll always say don't transfuse unless they've got bleeding symptoms, and don't manage the numbers. But this is a situation where you manage the numbers, and we aim for sort of quite strict targets. And this is very much national, international guideline driven. So you're keeping the platelets above 50, even if they've not got any evident bleeding, because they're at such a high risk of having spontaneous bleeds. And you keep the INR and APTT ratio less than 1.5, and keep the fibrinogen more than 1.5. Fibrinogen, as you know, you raise by giving cryo. General coagulopathy, FFP is better. Platelets. And then really, the only way of stopping this is starting prompt treatment with chemotherapy. It's the only way to switch it off, and it often gets worse before it gets better. But they can survive. APML is a subtype of AML, and it's got an excellent prognosis if they can survive the first week or two, and that's the big if. And it's caused, this is the geeky science bit, you can forget all of it or fall asleep for this bit, but it's a translocation of chromosome 15 and 17. Excuse me. We get fusion of a vitamin A receptor with an oncogene. So you kind of get activation of cell proliferation, but it gets stuck at the promyelocyte phase. So think back to that picture of those promyelocytes. So you just got to build up these promyelocytes, and they can't differentiate into neutrophils. And what that means is those cells are full of granules, they're full of cytokines, they're full of coagulopathic chemicals. So you get activation, but stuck at promyelocyte stage. And those promyelocytes and the cytokines and the granules they produce drive the DIC. So the DIC in APML is a particularly aggressive type of DIC. You have to, as we've mentioned in the last slide, aggressively manage the DIC. That block in differentiation can be unblocked by giving high doses of vitamin A, something called ATRA, all trans-retinoic acid. And then they all differentiate into neutrophils, which is great, but then it means you've then got a sudden burst of neutrophils. So all your promyelocytes that have been stuck suddenly become mature neutrophils. This is just a little picture. And then this rapid differentiation can then cause problems of its own. So you might be helping to switch off the DIC, but you then get huge cytokine release from having had a sudden shift in neutrophils, and that drives something called differentiation syndrome. So for that reason, we need to be giving chemotherapy at the same. Oh, what the hell's that? This is what it is. So it's when you've got those rapid, it's a cytokine sort of ARDS type of changing. So moving on to I've only got 4. So the next 2 cases are kind of looking at the other aspects. We've talked about DIC in AML. So these ones look more at the sort of hyperleukostasis, tumor lysis side of things. So this is a 36, I followed a bit of a pattern, the depressing one first, and then the sort of pick me up at the end. So the 36-year-old factory worker, a wife and 2 young sons, and he presents with a 2 to 3 week history of fatigue and shortness of breath. He had a white cell count of 129, platelets of 24, and he's admitted directly to haematology. Someone rang him, one of those scary phone calls, we're calling for haematology, you need to come to our unit now. He had a coagulopathy, and his bone marrow was consistent with the monocytic monoblastic subtype. He was given hydroxycarbamide, which is an oral chemotherapy just to try and control his counts. And then proper chemotherapy, IV chemotherapy, was started the next day. So all well and good, he was managed on the ward. He was carefully monitored for tumour lysis, and before his doses, he was given rasburicase. Again, we'll talk a little bit about that afterwards. Oh, that was a note for me to check what blood products he had, but clearly I didn't do that. So he had, on day 3, so he's still on one of the haematology wards, he had persistent pyrexia, worsening hypoxia. A chest X-ray showed left basal infection and changes consistent with fluid overload or pulmonary congestion. Actually, it probably was a bit of fluid. So when someone, if we're worried about tumour lysis, often we pour lots of fluid in. If he's got a white cell count of 100 and it's monocytic, he's probably got some leukemic infiltration as well, and probably a bit of cytokine release. So it's probably more a mixture of everything. He was still on the ward, but scoring up to 13 at times with tachypnea, tachycardia, hypoxia that sort of came and went. He was going from sort of 35% to 60%. It would always happen overnight, obviously, when there's one SHO on. DART came regularly and made sure we were doing all the right things. He had a CTPA because of this ongoing tachypnea and hypoxia. It didn't show any PE, but showed widespread ground glass opacification, infection, coronary edema. He had broad spectrum antibiotics. Day 11, he had new left eye visual loss, and the CT showed he had subarachnoid hemorrhage. He had worsening ground glass changes, and then somebody put 2 and 2 together and thought, well, actually, this is probably pulmonary hemorrhage. So he's got leukemic infiltration in his lungs. He's got inflammation. I think he's probably just bled into his lungs. I had worsening GCS and increased work of breathing. So he came to ITU. Initially managed on Optiflow, but fairly rapidly was intubated. Excuse me, I got all these from Nerve Centre, so I couldn't get the notes. So it's very, very brief. I haven't gone into the that's your guys' side of things, how you manage one ITU. But so you had intubated, ongoing acidosis, and GI bleeding, so blood in his aspirate, NG aspirates. It's requiring increasing doses of NORAD to support him cardiovascularly. He looked to be improving about day 5 to 6 on ITU, but then had a significant deterioration on his 7th day in intensive care, with worsening AKI, increasing oxygen requirement, increasing amounts of inotrope to try and support him, and it was felt that this was unsurvivable. At this point as well, he dropped his GCS just before he came to ITU and showed no sign of recovery, so he was made end of life. And then my balancing case is a lovely 50-year-old lady who had a past medical history of breast cancer. She was on tamoxifen and presented to ED with pleuritic chest pain, spontaneous bruising, and was referred directly to CDU. They thought she's on tamoxifen, she's got pleuritic chest pain, she's probably got a PE. She'd had a full blood count in A&E that had clotted. She had a CTPA which didn't show any PE, but showed some supraclavicular and axillary nodes. And then they got a white cell count, her full blood count back, and her white cell count was 900. We got a call, and we all sort of had this kind of, it was 4:30 on a Monday, everybody was going home. And we're like, so she was at Glenfield, so we got her over to the Royal and rang. I can't remember who was on call, but one of you gave me, got a lady with white cell count of 900. You very kindly accepted us basically straight to here with a very brief stop on OAU. For tumour lysis monitoring and organ support. She was given rasburicase. We were pretty convinced in this time that the appearances were consistent with ALL, just from the appearances of the cells and the fact she had lymphadenopathy. So we started her on steroids, which feels a bit uncomfortable with someone with a white cell count of 900. You think she could not be giving chemo, but steroid pre-phase is the treatment for ALL, so we did it. She had a bone marrow biopsy. She was sat here happy as Larry, going, oh, my chest pain's gone now. I don't really know what all of this is about. Bone marrow biopsy confirmed ALL. By day 3, her white cell count had gone down to almost a third of what it was. She had no change whatsoever in her creatinine, a very minor change in her phosphate and calcium. Basically blocked all your meds for 3 days, and then came back to our ward. She received treatment on the standard protocols. Just on the steroids alone, by day 7, her white cell count had gone down to 2. She did have some refractory disease, so she responded to treatment, but had some molecular detectable disease, so had some immunotherapy, and then had a haploidentical transplant, i.e. from a half match from her brother in April, and she's doing really, really well. And she has maintained an absolutely amazingly positive attitude through the whole thing, and is the kind of person that's got all the ward together, and they have little socials and ordered in pizza and stuff like that. So she's been absolutely amazing. And she's got ongoing molecular remission on her most recent bone marrow biopsy. So happy ones at end. So learning points about hyperleukostasis, hyperleukocytosis and stasis. So hyperleukocytosis is basically if the white cells are above 100, but we call it stasis if they then got organ compromised because of that. And mortality can be up to 20%, probably even more than that actually, when you combine that with the fact that they've probably got DIC as well and tumor lysis, up to 20% in the first week. And it's part of it is just mechanical. So if you've got a white cell count of over 100, white cells are much bigger than red cells, and it's just going to cause hyperviscosity and blocking of small vessels and all the damage that comes with that. Also, leukemic cells release cytokines, and they can increase the adhesion between the leukemia cells and the endothelium, so that the blood that is there is more sluggish. And then you get endothelial damage, and leukemic cells can infiltrate into the organs. So that's why it occurs. And what does it look like? Anything basically. So you can get lung infiltration, where you get, again, on imaging, it can just look like pulmonary edema or ARDS type picture, so pulmonary infiltrates. If they're then thrombocytopenic, those pulmonary infiltrates can quite quickly lead to pulmonary hemorrhage. From the CNS point of view, if you've got infiltration in the CNS, they can get headaches, visual changes. At worst, they can drop their GCS and coma. And then if you've got infiltration of leukemic cells into the parenchyma, you're then more likely to get bleeds. And these changes can persist for a week after, or even longer after those white cell count has changed. So that the first chap, his white cell count normalised fairly quickly, but he still had the effects of the tissue infiltration, which then caused the sort of intracerebral hemorrhage. It can be a cause of ongoing fever, which can be really hard to tease apart when they're neutropenic, so you cover them with antibiotics anyway. And it can add to it adds to the DIC and drive the DIC process. And then tumor lysis, which, as you can see, these three things, so the hyperleukostasis, the tumor lysis, and the DIC are all intertwined, because if you've got a high white cell count, you're more likely to get DIC, you're more likely to then get tumor lysis as well. So tumor lysis is basically the process of this rapid turnover of cells, and then you get a rapid release of the intracellular contents. And it can happen spontaneously. So if someone's got a really high white cell count or a massive bulky tumour, they can already start to lyse before they've even had treatment. But it most typically occurs when you start treatment, because you get this rapid reduction and lysis of cells. And the biochemical changes we normally see are related to the release of the intracellular contents. So potassium, a rise in potassium, a rise in phosphate in the uric acid, and an AKI. Predisposing factors, so bulky tumours, high-grade tumours, so acute leukemias and high-grade lymphomas, if they've got high LDH, and if they've got disease that's chemosensitive, so if it's an aggressive tumour that also responds to aggressive chemo, you're more likely to get it. And if they've obviously got any pre-existing renal disease, that will increase their risk. So the BSH guidelines consider ITU. So when they've got a high white cell count, part and parcel with all of this, we often will just ask you to kind of intervene, or at least keep a close eye on things for us. You mustn't replace, so often they have low potassium at first, and we specifically don't replace potassium and calcium because it's likely to rise as you start treating them. And then rasburicase is a urate oxidase, so a lot of tumor lysis is driven by this buildup of uric acid. So rasburicase binds uric acid and clears it renally. So that is the treatment of established tumor lysis. And if someone's high risk, you can give them prophylactic doses. And then obviously in fluidate, the usual triggers for renal renal replacement therapy. Yeah, tumoritis is probably something we manage it quite a lot on the wards, and only really if it got really severe, if there's something else going on as well, they come to you for it. So I guess the question is, with ITU involvement, so looking at all of these things, when best to admit, and we have had lots of situations where we've been worried, where we know there's potential for things to go wrong, and if you guys have capacity, you've always been excellent at saying, yeah, okay, we'll keep an eye on them for a few days. I guess it's not rocket science, and it's not particularly high quality study, because these things, when in acute situations, you can't do good quality studies. But a retrospective case matched review where they looked at basically if patients were admitted directly to ITU, if they had all these risk factors, if they had white cell count, high white count, and AML, and they were admitted directly to ITU versus admitting them to a ward and then admitting to ITU when they needed it. They could try to compare outcomes. So of the half that didn't go directly to ITU, half of them ended up going to ITU anyway, and they had increased intubation rates, increased use of vasopressors, and reduced survival. Retrospectively, you don't know how well matched they were, but it suggests that earlier intervention, they're going to get better monitoring. Our nurses are excellent on the ward, but there's sort of 3 nurses for 21 patients, many of which having chemo and are septic. So I think a lot of it is about probably intensity of monitoring. And the ability to escalate quickly if things go wrong. And then prognostic factors. So so there was a review that looked at in 400 AML patients what predicted the risk of having to go to ITU. Of AML, the 400 AML patients, about 15% went to intensive care, and it was mainly for respiratory support and management of hemorrhage. And there was an increased chance if there's low fibrinogen, concurrent infection, and comorbidities. Survival rate was 45%, which I thought was not bad actually. But less than that, there were people that didn't go to ITU, which again is not rocket science. But it didn't have any impact on their remission rates and relapse rates, which you wouldn't expect it to. But just as well. So take-home messages, thank you. So firstly, thank you for just looking after our patients and keeping them alive. I think we're really lucky here to have a really good relationship with you guys, where we can ring up and say we're really worried about this patient, and we know you'll help if you can. And I think not all hospitals are like that with where I've worked. So and please keep on trying. So I think with these depressing ones, I might go, oh, there, but you don't know which ones are going to be like that and which ones are going to do. So please keep trying. And sometimes it's just really shit, and patients die, and they're not going to survive. But again, we're not going to stop trying. So again, I've got to put that twice. I really mean it, don't I? Please keep trying. I don't know. Oh, that was it. So any questions about any of those, or any general leukemia questions, or anything you want me to go to in more detail about how to manage those things?
I was just wondering, what to expect for patients who come here and they already have alveolar hemorrhage? What's the outcome? Again?
Probably not good, but and I think again, I think you'd have to look at it in the context. I don't know the exact answer. I don't know a statistical answer to that, but I think you'd have to look at it in the context of what else was going on. If you felt their period of thrombocytopenia could be managed with product support, and actually the rest of their organ function was fine, and you felt that actually if you give them respiratory support and platelet support, and they've got a good chance of recovering, and they're either post their first cycle treatment or they're in remission, then I think you would just keep trying. You'd give them tranexamic acid, give them platelets, and hope for the best. But I think you know better than we would. I guess if you're then having to intubate them, that's going to increase your risk of further hemorrhage, I'd imagine, because of the pressures. And I think yes, I don't know the exact answer to that question, but probably fairly slim. Ian, any experience? Any?
There always used to be a case that Anne Hunter always used to quote to us every so often. A chap called Jonathan Duggan from years ago, who actually presented with alveolar hemorrhage in ED. So his diagnosis was made when he arrived in the with AML, and he survived that, but it was 6 or 8 weeks on unit and over units of blood.
Yeah.
But he still sends us a Christmas card.
I'm not surprised.
And his wife was 7 months pregnant.
Yeah.
Yes. But overall, actually, what I've seen over quite a long time is the improvement in survival of hematology patients that come to ICU. You know, years ago, they just didn't come because the outlook was so bad. Whereas now, you know, we're getting survival rates of about 50%.
Yeah.
And a lot of that is down to good communication early on. And so being aware of patients that are going off, and you know, the hematology team having a really good relationship with the ICU team, and we have discussions about patients, some of whom never come here.
Yeah.
And some are never going to come here because it would be inappropriate. But those early discussions are very, very important. So,
yeah, I did hematology. Well, I did ICU as an F1, and then my next job was hematology here as an F2.
I think I did it here
in 2009.
Ah, yeah, no, I think that was when I just rotated. I did it the year before, as an F2.
And there were quite a few patients that did in that job, and I think all but 2 of them died.
Yeah.
And that doesn't seem to happen as much anymore. We see it feels like most of the hematology ones leave.
Yeah, and I think it kind of depends on the point of their journey as well. So think about right at the beginning, and you know you've got a situation that's salvageable, and you can get them into remission. And like I say, a lot of 60 to 80% of people go into remission from their first cycle of chemo. If you can just get them through that period and switch off the process that's driving it, that's why we'd always be really keen, even if it looks like things are completely falling apart. If it is any chance it's survivable, let's try and get them into remission. Because once their counts recover and they get normal platelets, they get normal coagulation, and they have white cells back, a lot of it does quite rapidly get better. But
that's why the communication part is helpful.
Yeah, no, absolutely. And
generally, I think most of us, if you guys say that we should take them, then we will.
Yeah, and I think we've I think over time we've not tried to flog you people that we don't think are going to survive. So you trust us when we say we think we should take them.
Dr. Scott has got his hand up.
Oh, sorry, I'm not looking at the.
Sorry, I think I've got it on the phone. You there, Simon?
Yeah, can you hear me? Yeah, good. Sarah, thank you very much. That was fantastic. And really, really useful. I just wanted to ask a fairly technical question. So patients that we admit often end up on renal support.
Yeah.
So often, but that is quite frequent. But they stay on respiricase. And I was just wondering the rationale for that, or isn't there a rationale? It just feels like the right thing to do.
I don't think there is a rationale for that, in honesty. I think it just, if there's still evidence of, I guess if you still think this is being driven by tumolysis, which again is quite hard to prove, because once you're given rasburicase, it's quite hard to get an accurate measure of urate, because it binds it so quickly. So I think it's us just being cautious. It's incredibly expensive as well. So I think if the pharmacist got hold of that, they'll probably try and make us stop it.
Because the filter will clear urate.
Pardon?
The filter will clear urate. So it seems if they're on renal replacement therapy, it might just be a waste of money.
Yeah, no, I think it probably is. And I think if we've got to the point of they're having renal replacement therapy, we probably shouldn't be giving them. What we should be giving them is allopurinol, which acts further up the urate cycle. So you're stopping the urate forming in the first place. But rasburicase, like you say, is just binding that urate and taking it away. So I think you're just dialyzing out the incredibly expensive rasburicase. So what we should be doing is giving them allopurinol to reduce that burden of urate.
I'll cross it off in future. Thanks.
Yeah.
If somebody like in ED situation, in emergency situation, somebody presents like first case, they present with a shock. If they have high white cell count and you see some early infiltrates in lung as well, how would you guide us to go ahead with fluid status and,
Yeah, that's difficult. So I think that another thing to be aware of is these ones where they've got a high white cell count and lung infiltration is you want to give them enough fluid so that they're not getting tumolysis. But if you give them more fluid, they can get pulmonary edema and get more hemorrhage. So I think it's getting that balance. And I think in the first instance, if they're in septic shock, you have to go with bolus fluids and fluid management. But if you're then able to get art lines and central access and manage with vasopressors as well, that's probably the balance to do it. Once you're clear, you've given them enough fluid replacement, probably early use of vasopressors to limit the amount of fluid you're giving would be helpful, I think, because of the more, if they get an element of pulmonary edema, then they're more likely to hemorrhage. And just aggressive management, lots of platelets. If you're kind of giving them lots of blood products and lots of platelets, hopefully you're reducing that risk of hemorrhage as well. Tranexamic acid as well.
Kind of moving towards earlier vasopressors rather than loads of fluid in general anyway, for sepsis and other stuff as well. Probably the same.
Mm.
Thank you.
Thank you, guys.
Keep trying.
Yeah, so I said it twice, but no, genuinely
Don't give
helpful.
up.
Yeah, don't give up. So when I said to my colleagues that we're going to do a presentation to feedback in this case, like, make sure you balance it, and they don't just think that all leukemia is really shit and they're not going to try. I was like, no, I will. Oh yeah.
For those of you who don't know me at the other sites, I'm Charlotte. I'm one of the ACCS trainees.
Yeah.
And I'm going to be doing a quick presentation about this paper, which was on the BASICS randomized clinical trial on the effect of intravenous fluid treatment with a balanced solution versus 0.9% saline solution on mortality in critically ill patients. We'll start off by giving a bit of background about the paper itself, and then we'll use a structured format to analyse the paper. I'm hoping for some audience participation. I have got a Slido, so if you either want to put in the number or scan the QR code, I will put it up again before we start being a bit more interactive, but also any questions can go on there. So the background of this paper, as you can probably ascertain from the title, is looking at the intravenous crystalloids that we're going to be that we use in critical care. So as I'm sure we all know, intravenous crystalloids are very frequently used for fluid resuscitation, maintenance fluids, administration of intravenous medicines. So it's something that we use every day. There are previous studies that have suggested better outcomes in a balanced crystalloids, such as Hartmann solution, plasma lights, versus 0.9% saline. And so the objective of this study was to determine the effect of a balanced solution versus a saline solution on 90-day survival in critically ill patients. Now, apologies that this is quite a wordy slide, but this is the methodology of the study. So it was run across 75 intensive care units in Brazil and overseen by an external body. The recruitment, so the eligibility criteria were those patients admitted to ICU and requiring at least one fluid expansion and not expected to be discharged in the first 24 hours or less than 24 hours, with at least one of a set AKI criteria, which included age, low blood pressure, presence of sepsis, either invasive ventilation or non-invasive ventilation, signs of kidney dysfunction, and signs of liver derangement as well. The exclusion criteria were those who were expected to require replacement therapy very quickly after admission, any severe electrolyte disturbances, those who were anticipated not to survive the first 24 hours or shortly afterwards, and those who were suspected or confirmed brainstem death, also those who were previously enrolled onto the study. They were randomized via a central web-based automated randomization system with random permuted block sizes of 12, and it was double-blinded. So patients those using the fluids and then those analysing the data were all blinded to the intervention. They did their power calculations and estimated that they would, well, they targeted 11,000 as their sort of satarget number to recruit. So the intervention was plasma-light 148 with 0.9% saline being the control. The fluids were supplied by a central body with the only labelling on them corresponding to the study group with no other identifiable information. And these supplied fluids still were to be used for all fluid boluses, maintenance, and drug infusions greater than 100 mils for 90 days after enrolment. So the results, so just over 11,000 patients were randomised. Now, because they were retrospectively consenting patients, there was approximately 400 who did not give consent and so were excluded, and a small number that had been previously included in the study who were then excluded on their second round of randomisation. Almost 50% were admitted after an elective surgery, and just over 2/3 had already received some sort of crystalloid fluid bolus prior to arrival in ICU. So the median amount of fluid given in the first 24 hours following admission was very similar for the two groups. And then the primary outcome that was measured was 90-day mortality. And for saline, it was 27.2%, and for plasma-lights, it was 26.4%, which gives us a hazard ratio of 0.97 with a p-value of 0.47. So there were also some secondary and tertiary outcomes that were evaluated. The only statistically significant difference was in the day 7 SOFA score, and that was largely due to a higher neurological SOFA score in the saline group. So if you missed it the first time, this is the QR code. So we're going to be using the CASP RCT checklist in order to sort of structure our analysis of this paper. So if you do have any questions or comments on any of the points, then please do pop them in or shout out. So the first section, which is covering, is the basic study design valid for a randomized controlled trial? So first question, did the study address a clearly focused research question? Now, I would say that this had a fairly clear focus of its question. It was the intervention was a balanced solution versus a saline solution control, and the primary outcome was 90-day mortality. Question number 2, was the assignment of participants to interventions randomized? So they stated clearly what their randomization system was, and it was web-based, automated, and using random permuted block sizes, and it was double-blinded. And then were all participants who were entered into the study accounted for at its conclusion? So they have a very helpful diagram in the paper where they talk about who was recruited, which groups they were assigned to, and who was excluded and why. The major reason for people being excluded was them not giving consent to be included in the trial, and then the main other reason was that they'd already been recruited. The primary outcome data was available for all but 25 participants, and those lost to follow-up were included in the primary outcome analysis. And they talk about how they included them as well. Section B is about, was the study methodologically sound? So blinding. So were the participants, investigators, and people assessing the outcomes blinded? And for all 3 of those sections, that was the case. They were all blinded. Now, question 5, which is, were the study groups similar at the start? So they give a lot of statistics in the paper about the demographics and the characteristics. I couldn't find specific statistical analysis to say that there wasn't any significant difference. So that would be something that I'd want to know. But they themselves have stated that the patient characteristics were well balanced, but I'd like to see ideally some statistical analysis behind that. But looking at them myself, they appear to be sort of similar. And question 6 is, apart from the intervention that was being investigated, did each study group receive the same level of care? So were they treated equally? Now, because they were blinded, it's more reliable that they will have been treated equally. And if we look at what treatment they got in the volumes of fluid that they were administered, then it did appear to be quite consistent between the two groups. So section C, which is what are the results? So question 7 was, were the effects reported comprehensively? So here we like to talk about power calculations. So as I said before, the initial aim was to recruit 11,000. Now they did just recruit over 11,000, but ultimately because of exclusions, they analysed 10,500. And they did have clear outcomes. As we've already talked about, the primary outcome was very easily measurable with mortality. And because that is a binary outcome, it's best practice that they report both the relative and the absolute effects, which they did. They've given us p-values, and it has, and they were adjusted for potential confounders. From my sort of run through it, and if people have read the paper, did you feel that the results were reported fairly comprehensively? Yeah. Yeah. So question 8, was the precision of the intervention or treatment effects reported? So they did report their confidence intervals. So they did report.
So the bottom, it's the back of, I can't remember if it's the Balmoral or the Windsor end, but if you go to corridor level 0, it's one of those two. By MRI.
When I'm going to towards Windsor.
Yeah,
Yeah,
towards
go down,
it's one of the exits.
Go down to level 0, it's either the one at the lymph node bit in Balmoral or the lymph node bit Windsor.
Yeah, there's another one halfway along.
Yeah, there is. I can't remember which of those doors it is, but it's one of those.
Yeah.
There'll probably be some people around waving their arms about.
And someone who's painted.
No, that's all right. We were talking about precision. So there were confidence intervals and the standard deviation reported throughout. So their reporting was nicely. It was quite precise. And then we'd get into benefits outweighing the harms and costs of the study. So in terms of potential harms or costs, I'd like to hear people's opinions. You know, these are commonly used fluids and are fluids that we're well acquainted with. And so I couldn't think of any sort of specific harms other than, you know, the risk of, you know, high chloride in the saline group. But I don't know what other people's opinions are with this.
iatrogenic fluid overload, but that happens no matter what fluid you put.
Yeah. And then I suppose the benefits that we're looking at are the results of the study potentially they could influence our, fluid practice. Now, will the results help locally? So question 10, can the results be applied to your local population? Now, obviously this was all done in Brazil, but it was done over a number of centres, so 75 intensive care units. And ideally, we'd want to have an international study with centres from around the world. But from off the top of my head, I couldn't think of any reason why the responses to fluids in a Brazilian population would be, terribly different. But it would be something that ideally needs to be repeated. And then this is where I'd like to get some people's opinions. It is supposed to bring up your answers, but it's not going to do it. So if people want to shout out or raise their hands or yeah, Dr. Scott, you've got your hand up.
Thanks, Charlotte. That's really good. Very nicely presented. What I was going to ask, did they report secondary outcomes?
They did. There were a number of them, which there were 19 secondary outcomes evaluated. So I didn't want to get too much into the weeds of reporting all of those. The only one that had any statistically significant difference was the day 7 SOFA score, and the mainly due to the neurological SOFA score.
Okay. Did they look at renal replacement? Because that's usually the outcome with saline versus other solutions or starches, is the impact on renal replacement therapy.
I can't remember off the top of my head, but I do believe it was.
Okay, no, that's all right.
Yeah.
So, I mean, overall, I find these studies slightly frustrating. So, I mean, the main thing to say is completely underpowered.
Mm.
But even if it were correctly powered, you still need 14 or 15,000 patients to show potentially a small benefit.
Mm.
So they predicted a 35% mortality, but actually the mortality in the groups was less than that.
Yeah.
And that's a feature of these sort of studies that comes up all the time. And it's why a lot of trials show no significant values, because their predictions on how much they need to recruit is always too low. So it was unlikely to ever show anything that useful. The other thing, rather than looking at the p-values, and at some point I'll have a ranty talk about p-values, but is look at the confidence intervals. So for the paper's mortality, 27% versus 26.4% with a hazard ratio of 0.97. Well, the confidence intervals is 0.9 to 1.05. And that instantly tells you there is no difference. You don't need a p-value, because it's saying it either causes less harm or it causes more harm. Well, that's why you've done the study.
Yeah.
And I mean, do you think it's likely that the choice of fluid is going to make a difference to 90-day mortality in patients?
No.
I mean, that's always my problem with this. Why would a different fluid, which is essentially the same apart from the amount of chloride in it, make a difference to the mortality? It's most likely to make a difference to things like needing renal replacement or hyperkalemia rescue management and things like that, and length of stay. So this is yet another expensive ICU study of almost no use, in my opinion.
Yeah.
They did look at renal replacement therapy up to 90 days in a near occurrence of acute kidney injury. So they did look at it and didn't find a difference.
Yeah. And then you could argue it wasn't powered. Anyway, it doesn't matter. But anyway, so it's I would argue it's just not a very helpful or useful study, and doesn't add anything to our choice of fluids. So keep doing what you're doing is my view.
It's the problem with most ICU studies looking at mortality as a primary outcome, because actually mortality is really hard to find a difference, and there's other things that are as important.
Back very quickly.
Back very quickly.
I think, is that Dr. Little?
It is, yeah.
Yeah. Dr. Little's also pointed out that the local population for the LRI ICU isn't 50% elective, which is also, and they thought that that might have potentially impacted their mortality rates as well, because they actually had quite a high proportion of elective.
Hopefully your mortality rate for electives is quite low.
Yeah.
Hopefully, otherwise you're still doing something wrong.
So finally, would anyone change their practice? I think I can guess the answer. But yes. Any thoughts?
Maybe say yes.
There we go. That's enough.
Don't think I would. I think
No, I don't think I would.
Go with whichever one I think might be appropriate at the time, which is usually not normal saline, to be honest.
Yeah.
Cool.
Thank you.
Thanks, Charlotte.